beautiful session on my INICET जो that exam MDS May 2023. So I'm going to discuss both prosthodontics and your dental material questions. Kindly, why we have started this INICET series PYQs, so that you become benefit from these questions and these sessions. So my first question is, your denture wearer has the following issues on his follow-up and he comes up to a prosthodontist. So what are the following things that he can have? Okay, first is shattering of the teeth, old appearance of the face, okay, your soreness of the underlying tissues, and fatiguing of the masticatory muscles. Now the question is, which of the following is related to increase in the VD, means vertical dimension? Now we need to understand, in vertical dimension of occlusion there is something known as VDR, VDO, freeway space, and Silverman's closest speaking space. Four things you need to remember this. So I always say that VDR minus VDO gives you freeway space. That means VDR should always be greater than VDO, vertical dimension of occlusion, by the amount of freeway space. That means a right VDO should have minimum 2 to 4 mm of freeway space. Now we should understand, okay, so VDR is when the mandible is in physiological rest position. So when the patient is at rest, so just all of you just remain at rest, okay, just be calm and see how your mandible it slightly opens up and there is no contact between the two teeth, upper and the lowers. Now at rest, it's a static entity. Freeway space that was given by Thompson, तो उसकी वैल्यू 2 से 4 mm होती है ना. Why do we require a freeway space? We require a freeway space so that when the patient is at rest, the whole stomatognathic system, that is the TMG, the muscles, the teeth, everything remains at rest, because everything needs rest. हम 24 घंटे काम तो नहीं कर सकते ना. तो इसीलिए VDR should always be greater than VDO to have a correct vertical dimension, and should be greater than the freeway space. For example, हम बोलते थे VDR, for example, sir 70 mm, and VDO is, we say it is 67 mm. So difference is 3 mm. Perfect, no problem. 2 to 3 mm, perfect. Okay. Then there is something comes is Silverman's closest speaking space. Now this is a dynamic entity. It is dynamic entity, and it is at the, we record it at the function of speech. हम क्या करते हैं, we ask the patient to say s, ch, jh. So when the patient says s, ch, jh, the lower incisors, they move edge to upper incisors, and there is a gap between the teeth. They don't touch, but there is a slight gap. So if that gap is present, that means the VD is correct. That means the patient is having that space to perform that function of speech. That is very, very important. Okay, and mind you, it is the most closest way to see that your VDO and VDO is right or wrong. So VDR, I told you, VDR remains equal in all the ridge relations 1, 2, 3. But Silverman's closest speaking space, that is your dynamic entity, in class 1 it is around 1 to 2 mm. In class 2 it is more than 3 mm, and in class 3 it is 0.5 to 1 mm, that is less than 1 mm. So freeway space is less in case of class 3. Okay, now let us come on to the question. अगर हमारा VDO increased है तो क्या इफेक्ट होंगे, and if our VDO is decreased, so what will be the effect? याद रखो कि अब गुड कॉम्प्रोमाइज इज, ये भी क्वेश्चन आया हुआ है कि VD कम रखने में मान लो ज़्यादा फायदा है कि वीडियो ज़्यादा रखने में फ़ायदा है, हमेशा देखो हैं दोनों गलत, बोथ ऑफ देम आर रॉन्ग, बट अ बेटर कॉम्प्रोमाइज इज दैट यू कैन कीप अ लेसर वीडियो बट you can never keep video more. Vertical dimension of occlusion, you cannot keep it more, you require a freeway space, remember this. So what are the ill effects of video? देखो video means the teeth, there is no freeway space, so there may be shattering or the clicking of the teeth. ये perfect है, okay, there may be clicking of the teeth, okay, difficulty in swallowing, difficulty in speech. So, and when the patient, if there is an increased video, patient will have strained facial appearance. Strained facial appearance due to lower jaw, lower height increased. Lower jaw height will be increased. Lower facial height will be increased. There will be incompetent lips. Okay, there may be TMJ pain. Patient will not be able to eat well. There will be fatigue of the masticatory muscles. Difficulty in swallowing. Very important. There will be soreness of the underlying tissue. So एक क्वेश्चन आता है, increased video will lead to, there is something known as rich soreness, chronic rich soreness. या इसको बोलते हैं fleeting ulcers. मतलब you will not see any ulcers but the ridge will be sore. It may be slightly reddish but it will be sore. Okay, overexposure of the teeth. So these are the problems of increased vertical dimension of occlusion. TMJ problem, TMJ pain, these all are the problem. Fatigue of the muscles, ये सारी चीज़ें होती हैं. What is the problem with the decreased video? Decreased video means excessive freeway space. Excessive freeway space. So when there is an excessive freeway space, that means patient will have old senile appearance. क्योंकि जैसा आया था वैसे ही छोड़ दिया आपने. ठीक. Reduced masticatory efficiency. Reduced masticatory efficiency. There may be angular cheilitis. या इसको बोलते हैं परलेश, कुछ भी बोल दो, परलीके या परलेश, वॉट एवर यू वॉन्ट टू से. ओके. रिड्यूस्ड लोअर फेशियल हाइट, senile appearance, over closure. Okay, then muscle imbalance. Then last is your pain in the middle ear cavity. Pain in the middle ear cavity. Now the pain in the middle ear cavity, it may be because of the overclosure. The tongue, and there is a soft palate, tongue will press on the soft palate, and over the soft palate is the middle ear. There is a eustachian tube जो कि दब जाती है टंग के प्रेशर के कारण, एंड देयर इज अ डिफरेंशियल प्रेशर जिसके कारण पेन होता है. डिफरेंशियल प्रेशर के कारण पेन होता है. तो देयर, सो बिकॉज ऑफ डिक्रीज्ड VD, there might be pain in the middle ear cavity. So here the answers are 1, 3 and 4 are correct. So the answer here is first. It is the correct answer. I hope it is clear. The explanation इससे बाहर कुछ नहीं आएगा. Clear? Next question. Now consider the following, and ridge lap. Is it a ridge lap? Is it a modified ridge lap? Maxillary incisors, mandibular molars. So now let us match it. 1, 3, that is ridge lap and maxillary incisors. Okay, let us see. 2, 3, ridge lap and maxillary incisors. 1, 4 and 2, 4. So understand. So this is how ये साफ साफ दिख रहा है कि भाई हमारा ये pontic है, and it is in maxillary anterior. So if we see, there are So here the answer is 2 and 3, that is your modified ridge lap and maxillary incisors. Now how do you understand this? Now if we see the picture, so those pontics, those contact the mucosa in the anterior region. तो सबसे पहला आया था saddle, then आया था ridge lap, then modified ridge lap, then came the spheroidal, then ovate and modified ovate. The most aesthetic pontic in anterior aesthetic region is your ovate pontic, that is given in fresh extraction sockets. बहुत बार क्वेश्चन आया हुआ है, बहुत एक बार नहीं 1000 बार क्वेश्चन आया हुआ है वाला. Okay, now the problem here is when we see this is buccal and this is lingual. So if you see that it has a whole of the contact and then you give a teeth, that means this is a ridge lap. Saddle was, ये ridge है हमारा, ये यहाँ contact करेगा, यहाँ like a saddle, there was a space. तो तीन चीज़ें होती हैं एक pontic में. Is it aesthetic, it is hygienic, और is it and biocompatibility. ये तीनों चीज़ें होना ज़रूरी हैं. तो इसमें खाना फंसेगा. एस्थेटिक है बट हाइजीनिक भी नहीं है और बायोकम्पेटिबल नहीं है. वाई? बिकॉज योर pontic should have a minimal pressureless passive contact with the ridge, otherwise it may induce hyperplasia of the soft tissues. Passive contact, minimal pressureless passive contact on the ridge. There cannot be any blanching. Okay, so this was the saddle ridge lap. Now if this is the ridge, now modified ridge lap में ये एंड ये तो गया, लेकिन यहाँ से कन्वेक्स होके it goes like this. So exactly same picture this is forming, more contact on this and you have convexity and then coming like this and contacting point passive contact on the ridge. Modified ridge lap pontic, most versatile pontic that can be given in any region for that matter. Most aesthetic, one of the most aesthetic, hygienic and biocompatible. तीनों properties हैं only एक pontic में. It has a T-shaped contact with the ridge, लिख लो. It is also known as steel pontic. Okay, and it is mainly given in cases of maxillary anteriors, mandibular anteriors and maxillary posteriors. Mandibular posterior में हम उसे we can give a sanitary pontic. Clear है? Clear है? Most aesthetic pontic is your ovate pontic. Clear? ठीक है. So the pontic contacts only on the ridge, labial on the ridge side, providing good aesthetic, excellent. Lingual side is convex and clear of the ridge, allowing easy cleaning. Yes, and it is typically for anterior teeth for hygienic and aesthetic purpose. Okay, great. Any doubts till now? Is there any doubts? Let me see. Is there any? Any doubts? I know there are 4 students. Okay. Okay. Next, come on to question number 3. Retromolar pad is medially bounded by pterygomandibular raphe, masseter, temporalis tendon and buccinator. Okay, now when we talk about pterygomandibular, your retromolar pad, if you see this is a soft triangular pad present in the third molar area. Okay, okay, so pterygo, it is, mind you, this is one of the, up now if it comes, see, it is a definitely, it's a primary retentive area, primary retentive area for the mandibular denture, और मेन प्राइमरी पेरिफेरल सील एरिया कर सकते हैं, प्राइमरी पेरिफेरल सील एरिया of the mandibular denture. Okay, okay, and remember one thing, that there are, if it is given, for example, 4 choices are given, for example, more, the best primary retentive area for mandibular denture is your definitely retromolar pad. Okay, and it decides the distal limit of the mandibular denture. Very good. Is it the primary supporting area too? In recent edition of Boucher, it has also been included along with the buccal shelf area plus the retromolar pad area in a primary supporting area also. So if the question में अगर अलग अलग दे रखे हैं, buccal shelf area, retromolar pad, if third option is both, तो आंसर both होगा, लेकिन अगर both option नहीं है तो again you answer buccal shelf area is a primary retentive area, but if you see that even in highly resorbed bridges, the buccal shelf area and the retromolar pad, they remain as such, they don't resorb as such. So that's why, seeing all this, even the retromolar pad has been considered now as a primary supporting area along with your buccal shelf area. But if the option are single and there is nothing known as all of the above or both of these, so the best answer still will remain buccal shelf area as a primary retentive, primary stress bearing area. Why? Because it is made up of buccal shelf area is made up of thick cortical bone, okay, it is at 90 degrees to the force, masticatory forces, and it is surrounded by muscles attachments. That's why it doesn't, surrounded by muscle attachments, that's why it doesn't resorb. Okay, okay, now let us come on to the question कि भाई रेट्रोमोलर पैड एक, तो याद रखो कि ये हमारा, दिस इज मीडियल एस्पेक्ट, दिस इज लैटरल एस्पेक्ट, दिस इज एंटीरियर एंड दिस इज पोस्टीरियर एस्पेक्ट. ठीक है, तो पोस्टीरियो मीडियली यहाँ पे हमारा कहीं ना कहीं आके हमारा अटैच होता है हमारा टेरिगो मैंडिबुलर रैफे. मेसेटर इज हेयर पीछे, टेम्पोरल स्टेंडेंट भी कहीं डिस्टली ही अटैच होता है, एंड बक्सिनेटर इट कम्स फ्रॉम टेरिगो मैंडिबुलर रैफे, इट कम्स ऑन बक्कली इन दी बक्कल सल्कस. सो द बेस्ट आंसर हेयर इज टेरिगो मैंडिबुलर रैफे. Okay, so it is medially bounded by pterygomandibular raphe, that is a fibrous band of the tissue that extends from the pterygoid hamulus of the sphenoid bone to the mandibular retromolar area, to the medial aspect of the retromolar area. ठीक है, and remember this raphe serves as an attachment to buccinator muscle anteriorly, okay, and posteriorly by the superior pharyngeal constrictor muscle. Okay, so anteriorly it has an attachment of this pterygomandibular raphe, as an anteriorly has an attachment of buccinator and posterior as a superior constrictor muscle. ठीक है, तो जैसे मैंने बोला masseter lies laterally and posterolaterally. Okay, it is not present in this. ठीक है, ठीक है, और टेम्पोरली स्टैंडन थोड़ा सा और पीछे होता है, कोर्नर प्रोसेस पे आके नीचे आके आता है, एंड बक्सिनेटर कैन नॉट बी बाय बिकॉज बक्सिनेटर इज अटैचेस टू दी टेरिगोमैंडिबुलर रैफे, बट इट इज स्टिल नॉट मीडियल. ओके, इट रन्स फ्रॉम देयर एंड देन कम्स टू दी बक्कल वेस्टिब्यूल. सो द बेस्ट आंसर हेयर इज द मीडियल एस्पेक्ट ऑफ द retromolar pad is your pterygomandibular raphe. I hope it is clear. HS, Nimisha, SR, clear है बेटा? In an implant arrangement, the post which comes out of the Okay, the post which come out of the, not tooth, but the post which comes out of the implant. Now this is a very, the language of the question is not that great. Okay, ठीक है. तो एक इम्प्लांट में, इम्प्लांट, ये इम्प्लांट है. Okay, and the post that comes out from the implant, okay, is called as, so definitely it's an abutment post या abutment, it's an abutment or an abutment post where we give the crown. Okay, तो इम्प्लांट से ऊपर जो इम्प्लांट से कनेक्टेड होता है, जिसमें हम क्राउन देते हैं, दैट इज योर अबटमेंट पोस्ट और द अबटमेंट, इम्प्लांट अबटमेंट, दैट एक्ट एज अ कनेक्शन बिटवीन योर, दिस अबटमेंट इज एक्टिंग as a connection between your teeth and implant, your crown and implant. Okay, your implant fixture is the implant that you have placed. So if we talk about the implant, so implant का ऊपर होता है, there is something cervical geometry. और क्रिस्टल मॉड्यूल, सर्वाइकल ज्योमेट्री, और उसको बोलते हैं क्रिस्टल मॉड्यूल. इट इज द माउथ ऑफ द इम्प्लांट वेयर all the components like your gingival former, covered screw, abutment, the everything joins on the crestal module. Then is the body of the implant, and last is the apex of the implant. Okay, इम्प्लांट एनालॉग इज दी, देखो इम्प्लांट एनालॉग समझने के लिए, इम्प्लांट इज देयर इन दी बोन, सो वी नीड टू प्रोड्यूस अ हम शक्ल ऑफ, या बिल्कुल एनालॉग ऑफ द इम्प्लांट. वी कैनॉट रिमूव द इम्प्लांट फ्रॉम द पेशेंट्स माउथ एंड पुट इट इन द कास्ट. सो इन द बेस ऑफ द कास्ट दैट गोज, द कॉम्पोनेंट दैट गोज इन टू द बेस ऑफ द कास्ट एंड मिमिक्स द इम्प्लांट, that goes into the base of the cast, that is your implant analog. Okay, clear है. Last question, very not a great question, but still, an edentulous patient comes to a prosthodontist with a large tori in the palate extended to the junction of hard and soft palate. Okay, patient आया, इंसिजर पैपला यहाँ से टोरा, ये जो कि यहाँ से हार्ड और सॉफ्ट पैलेट के जंक्शन तक है. ओके, हाउ विल यू मैनेज दिस केस? पुट अ होल इन दी, वुड यू रिलीव दी CD टू एनहेंस द रिटेंशन स्टेबिलिटी? वुड यू प्रोवाइड अ होल इन दी CD? नो. सर्जिकल एक्ससीजन टू इंक्रीज रिटेंशन स्टेबिलिटी एंड इंक्रीज द डेंचर बेस्ड मटेरियल इन द एरिया ऑफ द टोरस टू गिव रिटेंशन. बेटा याद रखो, जब भी टोराई हो, चाहे मैक्सिला मैंडिबल, द बेस्ट आंसर इज सर्जिकल एक्ससीजन ऑफ द टोराई to enhance this tension and this stability. Why? Because on the tori, first of all, the mucosa will be thin and friable. तो जब भी इस पे फोर्स पड़ेगा, चाहे आप कितना भी रिलीव कर दो, there will be some fulcrum, there will be some forces, and it might lead to your the pain, ulceration. So best in RPD, CD, best first option is to remove it, and especially a tori like this. Okay, so you have to be careful when you are removing the tori, because it is also known as exostosis. Okay, maxillary exostosis or torus palatinus, right? So the best answer is surgical excision. ठीक है, normally it is normally asymptomatic. Okay, but if it requires a denture, a completely edentulous patient or a cast partial, then it will lead to problem in speech, it will interfere in the denture seating, there will be patient discomfort, as I told, ulceration, and because of the intimate contact, it's a very hard structure, there will be some speech and masticative difficulties, hygiene issues, reduced mastication efficiency, and all of these will be a problem. So I hope it is clear. interference with the denture seating, discomfort and ulceration, reduced retention and stability, speech and mastication difficulty, hygiene issues and ठीक है ठीक है. होल क्यों नहीं बनाते डेंचर में भाई? होल इसलिए बनाते डेंचर की फिट में, डेंचर की स्ट्रेंथ में देयर विल बी प्रॉब्लम, देयर विल बी फूड लॉजमेंट. व्हाई डोंट वी गिव रिलीफ? Relief is normally for your small tori. Large tori, if we relieve too much, there will be rocking and instability. Okay, we cannot add more bulk to the denture based material, and it is highly impossible to cover the whole tori, so it will be a problem. So best is remove it surgically. Remove it surgically. Last question. और जब रिमूवल करने के बाद it will lead to proper adaptation of the denture base, improve retention stability, better distribution of occlusal forces, and after healing we can give a new denture. Okay, last but not the least, it's a very confusing question, but I have taken it from a very classic article, the explanation from JPD, Journal of Prosthodontic Dentistry, 1963. Okay, oral mucosa of the denture wearer differ from the non-denture wearer in what sense? Is there an increased keratinization and increased fibrosis? First option. Atrophy of the masticatory muscle over the period of time, increased fibrosis अगर denture loose है, and decreased keratinization over time. It's a very tricky question. The best answer here is your increased keratinization and increased fibrosis. The best answer. I will tell you why. देखो, atrophy of masticatory muscle is write down, it is an indirect denture sequelae. It is an indirect problem. Why? Because the teeth are not there, the proprioception is not there. Okay, the patient remains edentulous even after giving dentures. The working length of the masticatory muscle is not reached, so there is an atrophy of the masticatory muscle because of disuse atrophy. So yes, but it is not related to the mucosa here. Okay, now let us see the answer. The first answer is up. Okay. Now when we wear the dentures and under normal cases of well adapted dentures, now because of those, now earlier there was nothing. Okay, when there are dentures, होल क्यों नहीं बेटा होल कर देगी तो रिटेंशन कहाँ से आएगी? सील कैसे बनेगी? डेंटल बट पॉलीक्लिनिक बेटे, होल कर दोगे तो देयर विल बी लॉस ऑफ रिटेंशन, एयर पास हो जाएगी ना, कैसे करोगे बेटा? और खाना जाएगा, बहुत सारी प्रॉब्लम्स होंगी, इसीलिए होल नहीं कर सकते. राइट? ओके, क्लियर है? डेंटल बट पॉलीक्लिनिक क्लियर? ओके. So, wearing dentures particularly over a large period leads to adaptive changes in oral mucosa. Okay, and it will lead to mechanical stress, mechanical pressure. Now, because of this mechanical pressure, it might lead to increased keratinization. Okay, because of the constant pressure, it will adapt. There will be friction. There will be keratinization, and keratinization is not कि बहुत ज़्यादा keratinization. It is for extra protection of the tissues. So, it's a compensatory phenomena. Then if there is a chronic irritation from the denture, it can also lead to increased fibrosis. Now it is there. Now the denture might lead to an exaggerated response too. The denture may become the tissues or the mucosa may become increased fibrotic if it is loose. So the first option is giving you more explanation. The best answer here is your increased keratinization and increased fibrosis. Atrophy of masticatory muscle, I have told you it is more related to the teeth. It is not related to the mucosa, changes in mucosa. It's an indirect sequelae. Sirf increased fibrosis if denture is loose is partially true, but it is specific to loose fitting dentures. It may happen over time from a normal denture, but it is specifically true for the loose dentures. And decreased keratinization, normally keratinization increases with chronic denture use, and also the thickness of the mucosa decreases with overuse of the कि हम बहुत समय तक denture use कर रहे हैं, even the thickness of the mucosa decreases. ठीक है, even the thickness of the mucosa decreases. Okay, so the best answer here is your increased fibrosis and increased keratinization. Okay, clear hai? I hope it is clear. Now let us take any doubts in the prosthetic part. Now let us discuss the dental material questions. Okay, okay. Relative inability of the material, it is INICET MDS May 2023. So relative inability of a material to sustain plastic deformation before fracture of the material is known as, very important question, it is brittleness. Brittleness का मतलब है 0% परसेंटेज elongation, 0% elongation, मतलब इट विल नॉट, इलास्टिक रीजन से थोड़ा सा भी प्लास्टिक रीजन में आया तो टूट जाएगा. इसका मतलब मटेरियल क्या है? वेरी ब्रिटल. इट डजंट हैव इवन वेरी लेस प्लास्टिक, इट विल नॉट सस्टेन द प्लास्टिक डिफॉर्मेशन. वाई? बिकॉज देखो हमारा जब ग्राफ होता है, इफ वी सी द ग्राफ like this, so till this straight line it is under elastic region, then it becomes plastic deformation. तो stress versus strain, if we see this, so elastic region तक force लगी है तो it will not break, but as soon as it reaches the plastic deformation and permanent deformation, it breaks. That means it is not able to sustain plastic deformation. So the best answer is brittleness. Hardness is how hard is the material or the resistance to indentation. Okay, resistance to indentation. ठीक है. Fracture toughness, fracture toughness is basically the sum of the elastic plus the plastic region. तो how tough is the material means यहाँ से force लगी, इलास्टिक रीजन क्रॉस किया, प्लास्टिक रीजन क्रॉस किया, फैटीग हुआ, फिर टूट गया. टूटने से जस्ट पहले कितनी उसने फोर्स दिखाई, कितना उसने सहा, उसको बोलते हैं फ्रैक्चर टफनेस. एंड मॉडुलस ऑफ इलास्टिसिटी, मॉडुलस ऑफ इलास्टिसिटी इज द, एज आई टोल्ड यू इन माय प्रीवियस क्लास, इट इज द slope, it is a straight slope or the straight line, that is stress versus strain. Okay, it is the relative toughness, or sorry, relative rigidity or the stiffness of the dental material. More the modulus of elasticity, more it will be rigid. Okay, clear है? तो modulus of elasticity, right, I have told you. तो hardness, as I told you, it is resistance to indentation or scratching, right. Fracture toughness, मान लो किसी भी material, if there is a slight crack in the material, then it is the material's ability to resist fracture when the crack is present, and it is related to energy absorption and crack propagation. Okay, Young's modulus, I have told you, measure of relative toughness. Okay, it will not describe any plastic deformation or fracture behavior. Why? Because it is only in the elastic region. I hope it is clear. Okay, next question, which is not a processing wax. So if you see the classification, okay, so if you see the classification, so processing waxes are the waxes that are used in helping or assisting the laboratory procedures, but not directly creating final restoration or definitive processes. So such are the processing wax. So which is not a processing wax, your utility wax is a processing wax, your sticky wax is the processing wax, your boxing wax is the processing wax. Okay, so if we see that your processing wax is mainly for extension of the tray borders, for sealing, for cushioning, It is not related to the final processes, absolutely not. दो फ्रैक्चर्ड पोर्शन ऑफ द डेंचर हैं, उनको होल्ड करने के लिए चाहिए स्टिकी वैक्स. बॉक्सिंग वैक्स, अगेन इट्स अ प्रोसेसिंग वैक्स, that is after beading we do boxing, that will define the base of the cast. Casting wax or the inlay casting wax, it is not a processing wax because it is directly producing the wax pattern, it is directly producing the final prosthesis. So the best answer here is your casting wax or inlay casting wax. Very important information. Clear hai? Clear? Okay. Remember one thing, that whenever you are, ideally the wax pattern of the inlay wax should be immediately invested after formation. Why? Because there are release of the stresses, there might be deformation, and if you are not able to invest it immediately, then you should at least keep in refrigerator. आधे घंटे तक रख सकते हो, ज़्यादा से ज़्यादा इससे ऊपर नहीं रख सकते हो. Clear? तो ideal question is you should invest it as soon as possible. Clear? Next question, 18 to 30 fluted carbide bursts, मतलब फ्लूट बहुत ज़्यादा हैं. तो जब फ्लूट बहुत ज़्यादा होते हैं तो उनकी पिच कम होती है. देखो, if less flutes are there, for example 3 or 4, that means the space or the pitch between the flutes is more. And if in the same work, if you are having very very closer 18 to 30, that means the pitch is less. So when the pitch is more in less number of flutes, it will bite more. So it will be mainly used for your contouring and removing anything in bulk. So when you are having more number of flutes, carbide burrs, you will have less pitch, you will have less bite, so it will be mainly used for finishing procedures. Clear है? Clear है बेटा? तो less flutes, it is for aggressive cutting, it is reduced for contouring, it is used for removing the material quickly. Moderating flutes like जो हमने दे रखा 18 से 30, less aggressive, produce a smoother surface, but still there will be some irregularities. If you have flutes more than 30, that means it will produce very beautiful smooth surfaces, it will not cut, it will polish. So their ideal 18 to 30 flutes will be ideal for finishing, smoothening the margins, refining the contours. Okay, so I hope it is clear. False statement regarding PMMA is, okay, false statement regarding PMMA, polymethyl methacrylate, Knoop hardness number is 18 to 30. Okay, modulus of elasticity is 2.4 gigapascal, tensile strength is 40 megapascal, and chemically stable to 260 degrees. Now this is a very difficult question, you need to mug it up. So here the answer is the tensile strength is 40 megapascal. It's a false statement. Knoop hardness number 18 to 20 is fine, it is okay, it is a correct choice. Modulus of elasticity 2.4 gigapascal, it is absolutely perfect, and it is chemically stable to 260 degree Fahrenheit, absolutely fine. Okay, so the tensile strength is between 50 to 77 megapascal. Okay, it is chemically stable to up to 260 degree Fahrenheit या 130 degree Celsius. तो remember one thing, that इसकी जो tensile strength है इससे ज़्यादा है, not 40 but it is in the range of 60 to 70, 50 to 70 or 50 to 80. Clear? Clear? Okay, all can be used for blocking undercuts intraorally except, okay, can we use irreversible hydrocolloid, for example, if this is the case? Okay, so if there are lots of undercuts, for example, there are a lot of spaces between the teeth, there is a lot of periodontal condition, okay, there are a lot of spaces, तो हम impression लेने से पहले either we can use cotton to to place in the undercut so that the impression material doesn't go into that and it can be easily retrieved. Can we use irreversible hydrocolloid? Yes, we can use. Addition silicone, any putty? Yes, we can use. Processing wax? Yes, we can use. Can we use fast setter plastering of Paris? It is totally avoid to block undercuts. Intraorally, remember this. You can block the undercuts in the cast by plaster of Paris and with the addition of your pumice plaster, but not intraorally. But not intraorally. Clear? So we can use impression materials, lock into the undercuts, we can use processing waxes, we can use cotton buds, but we should not use your fast setting plaster. Why? Because it is hard, brittle, it is not safe to block the undercuts. It can lock, it can remain there, it is not a flexible material, it won't come out. Silicones, yes, can be used to block the undercuts, easily removed. Okay? It is malleable. The processing wax we can use ideally for this purpose. Okay? Any doubts? Any doubts? So I hope it is clear. Any doubts till now? I am waiting. बेटा अगर कास्ट पे होता तो कास्ट पे तो आप ये यूज कर सकते हो, बट इंट्राओरली यू शुड नॉट यूज. इट इज वेरी मेसी टू वर्क. Any doubts or any topic you want me to so that I can make you understand? I am waiting. Nimisha, HS, Polyclinic. Just 2 minutes I want to take. And there was a question that I personally want to take. Is a topic on the topic is truing and dressing. Truing and dressing. Now, the dressing का क्या मतलब है? Dressing is basically cleaning and restoring the cutting efficiency of a dental burr, of an abrasive instrument. It might be a wheel, it might be a stone, it might be a burr. तो जो क्लॉगिंग हो जाती है हमारे बर के बीच में, मान लीजिए बर के बीच में क्लॉगिंग हो गई, तो उसका कटिंग एज वोंट कट द वर्क पीस, द कटिंग एफिशिएंसी विल बी लेस. तो वी हैव टू रिमूव द डेब्रिस, वी हैव टू रिमूव द क्लॉग मटेरियल, वी हैव, सो दैट वी कैन क्लीन इट, वी कैन एब्रेड इट. ओके, तो पर्पस क्या है? पर्पस ये है कि भाई साहब जो हमारे जिस एब्रेसिव की वजह से हमारा कट करेगा, अगर वो हमारे क्लॉग हो जाएं तो उनको हमें वापस रिस्टोर करना है ना. ठीक है, कैसे करते हैं? वी कैन यूज अ ड्रेसर. ड्रेसिंग मीन्स रिमूविंग द क्लॉग्ड डेब्रिस. उनके हम किसी एक, मतलब हम कोई भी कार्बोरेंडम स्टिक या एब्रेसिव ड्रेसर या डायमंड स्ट्रेसर के अगेंस्ट उसको चलाते हैं. ठीक है, ताकि जो हमारा मटेरियल है वो चला जाए अंदर से. सो वी रन इट अगेंस्ट अ रोटेटिंग व्हील. That may be a carborundum stick, it might be an abrasive dresser or a diamond dresser. Truing is basically, truing का क्या मतलब है भाई? Truing is basically reshaping and correcting the geometry of the instrument, of the rotatory instrument. Now, अब होता क्या है? If you see, इट इज बेसिकली करेक्टिंग द ज्योमेट्री. मतलब अगर देखो आपने कभी ये देखा है जब आपका बर नीचे गिर जाता है और चलाते हो तो वो ऐसा नहीं घूमेगा स्ट्रेट, वो ऐसे 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 घूमेगा, ऐसे ऐसे. दैट मीन्स वो कंसेंट्रिक नहीं है. कंसेंट्रिक मतलब अगर कोई चीज़ घूम रही है, अगर वो 100 की स्पीड से भी घूम रही है, 200 की, तो बिल्कुल एक परफेक्ट सर्कल बनाएगी. तो अगर मान लो वो गिर गई है, टूट गई है, या उसकी ज्योमेट्री खराब हो गई है, तो वो एक जब घूमेगी इट वोंट बी रोटेटिंग इन अ कंसेंट्रिक सर्कल. इट विल बी लाइक दिस, कर 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 लाइक दिस. इट माइट बी वॉबलिंग. वेरी गुड शिवानी. ओके, so a perfect circle while rotating, that means it has to be concentric. It cannot be eccentric. ठीक है. Now how to do it, how to reshape it, how to true it? So it prevents the vibration and ensures the accuracy in grinding. How to do it? Now what we do is, if such thing happens, so there is a मान लीजिए कोई अगर ऐसे हो गया है ना, कंसेंट्रिक नहीं है, तो हम क्या कर सकते हैं, व्हाट वी कैन डू इज वी कैन स्टैंड इट अगेंस्ट अ मोर, जिसका एब्रेजन रेजिस्टेंस ज़्यादा हो. एन एब्रेजिव हुज एब्रेजन रेजिस्टेंस इज मोर देन दी वर्क पीस. तो व्हाट वी कैन डू इज वी कैन जस्ट रन इट अगेंस्ट दैट फ्लैटर सरफेस. तो व्हाट विल हैपन, जो भी हमारा एक्सेंट्रिक पार्ट होगा वो हट जाएगा, ओनली कंसेंट्रिक पोर्शन रह जाएगा. राइट. फॉर एग्जाम्पल हमारे इफ़ यू सी आफ्टर यूजिंग टू मच ऑफ चेरी स्टोन्स, यू सी दैट जो हमारे चेरी स्टोन्स होते हैं वो हमारे थोड़े रफ हो जाते हैं. तो व्हाट हमें उनको ट्रू करना है, तो कैसे करेंगे, वी रन दिस सरफेस अगेंस्ट अ मोर फ्लैटर सरफेस. तो ये बेसिकली सबको वो कर देगा कि ट्रू इट, रीशेप इट. तो रिमेंबर दिस, रीशेपिंग एंड करेक्टिंग द ज्योमेट्री is truing, and dressing is basically cleaning and restoring the efficiency of the workpiece. Clear hai? I hope it is clear. Any doubts? Clear? So I hope we have done some justice to our teaching. I hope you have understood the INICET May 2023 paper. See it once again, see how the questions are there. We at AIIMS provide you the concepts so that you can build it, your knowledge. You can answer much more questions, conceptual questions that will be there in INICET. Okay, signing off, Dr. Chetan Pathak this side, Prosthodontist. Okay, and all the best. Good